Welcome to Health and Harmony Beyond the Teeth, where we dive into all subjects that will help you become healthier and happier. As a dentist, I believe dentistry is more than just teeth, so I created this show to focus on overall health. We will hear from leading experts about eating better, exercising better, breathing better, and sleeping better. We want to help you create harmony in your life so you can live your life to the fullest. We want you to thrive. Hello, everyone. Welcome to another episode of Health and Harmony Beyond the Teeth. We want to welcome all the doctors, all the myofunctional therapists, all the physicians, all of the moms and dads and patients that watch this podcast. We've got a great one today. We've got Dr. Tim Adams. We're going to be talking about quantum physics, craniofacial posture, airway, tongue position, cranial bone movement, and the autonomic nervous system. It's going to be fantastic. Tim is one of my most respected colleagues. I love him to death. He's a great guy, and he's full of wonderful information that will be beneficial for everyone watching this podcast. So, Dr. Tim Adams, I want to welcome you. Thank you for being on today.
Thank you, Hal. I appreciate it. And the check's in the mail, brother.
All right. I hope you sent it overnight, because
I will. I promise. You heard that before.
So anyway, Timmy, I call him Timmy. Sometimes I call him. I probably should just refer to you as Dr. Adams. You've earned that degree many times over, that accolade. Why don't you tell us a little bit about yourself, and then let's just dive right into this extremely fascinating subject, because we're both dentists, but we deal with much more than teeth. We have chosen to go a route that we feel is significant in patients' health and well-being and longevity. And Dr. Adams is right on the cutting edge of all this. So I've learned a lot from him, and hopefully you guys will learn more tonight or whenever you're watching this podcast. So, Tim, I'll let you take it away here, and we'll just let you go through. And if those of you that are listening to this podcast, you'll get a lot of information out of this. But if you can go onto the YouTube channel, Health and Harmony Beyond the Teeth on YouTube, and watch it, so you can see some of these incredible visuals that Dr. Adams is going to be throwing up, that'll be even better. But if you're in your car and you're just listening to this, you're going to get a lot out of it. So great information. So Dr. Adams, the floor is yours. Take it away.
Hey, I appreciate it. And I'm honored to be here and flattered that you invited me to come to speak, to share this information. So I'm just going to kind of roll along. This is some of these trying to present years and years of information into a 45-minute or so podcast is always challenging, but I'll do my best. But Hal's going to stop me at any point in time and ask questions. So I'm kind of an unknown in industry. So for those of you that really don't know my story, I started early on when I graduated from dental school as an aesthetic guy. Even though aesthetics at that time you really shouldn't have done because they didn't have the bonding materials at that time. It shows my age, I guess. But so I wanted to be an aesthetic dentist early on. I had the incredible opportunity to train with some of the best in the country. I got a chance to teach out west at one of the leading institutions in the country. I was the clinical director out there for 3 years. And what I learned along this line is I learned about golden proportions and how important that was in nature, and taking that to teeth also. I also learned about smile design, where you can have the most beautiful veneers in the world, but if they don't look good from a gummy facial tissue standpoint, it's not going to be a wow case. And then as we went along in this journey, we realized that there are some of these cases, veneer cases, that were turning into TMJ. And then what we realized was we really weren't managing the bite properly. So we got that under control, and then got into neuromuscular dentistry. Had the wonderful opportunity to teach with Jim Gary and Bob Jankelson side by side, and that was great. But I also learned that I wasn't going to cure bruxing by just a neuromuscular appliance. And then I got into sleep and realized that there were really two different bites. There's a daytime bite, but also a nighttime bite. And as I went along, I'm always asking, one of my mentors, most powerful mentors that I ever had, would always tell me, there's one word, Tim, that you've got to ask yourself and never quit until you answer it, and it's why. Why? And so I was asking myself, why aren't these appliances working the way I thought they should? One thing led to another, and I started to realize when I saw my cases come in that there was a common denominator. And that common denominator was in maxillary arch that was restricted. And all of a sudden, that kind of led me down a bunch of different rabbit holes. So I could have stopped at 2 bites in airway and sleep. But then I started to look at epigenetics and quantum physics, started to look at breathing and nitric oxide, which is a whole different animal that we're not going to talk about today. And then I started to look at these cranial strain patterns, which is basically facial asymmetry. And then biotensegrity and fascia, which really is what gives the body its life, what gives the body its form, what holds the body up, and how signals from the outside are communicated throughout the body, which is termed mechanical transduction. And I started to utilize a device called a Cricket appliance. I started with a homeoblock device. And the homeoblock, I had wonderful success with it. Was used, I've used it for about 17 years, treating my TMD patients and airway patients. I had the wonderful opportunity to meet Ted Belfour and teach with him. He has since passed away, but he was a wonderful mentor for me also. But there were some things about the homeoblock that didn't sit right with me. And I didn't like the fact that it was a bunch of acrylic up there, not giving the tongue ample space to go anterior superior. And I didn't like the fact that it crossed the midline, because as these cranial bones move and they expand and contract 10 to 14 times a minute, if you block them or brace them, they can't function as ideally. And cranial fluid is pumped by these cranial bones in the occiput and the actual hip. And so if they're not flowing properly, the brain isn't nourished and oxygenized. The metabolites and toxins in the brain aren't drained through the jugular vein. And then the other thing that people don't realize is that cerebral spinal fluid actually cools the pituitary and the hypothalamus, and those are your hormones. And if it's off a tenth of a tenth of a tenth of a degree, it makes a big, big difference. So this is kind of where I'm at today. And you know, in the sleep world, we treat with medications, which I'm not a big fan of, but that's the way that's the Western medicine model, quite frankly. We treat with CPAP, which is really pretty much a reverse vacuum cleaner. But the thing I always wondered about CPAP machine is, what is it doing to the cranial facial structure when it's strapped on the face? And the other thing I always wondered about was, what's it doing to the nitric oxide concentration? Because you're forcing air down the throat and you're not getting nitric oxide that way. And so I always wondered about that. And then we treat with mat appliances, which is kind of the standard in the industry right now. A big chunk of acrylic that's in there that blocks the tongue. And basically it's like, I'm not really sure. And so I thought to myself, wouldn't it be nice to attempt to treat the root cause of the craniofacial asymmetry and airway and neurology? Because if you start to look at these patients, there's a whole different animal that we're not trained to look at as dentists. And so instead of treating the expression of the root cause with appliances, my thought was, why don't we take the Band-Aid off and treat it the way it should be, which is the root cause? And to do this, you've got to start thinking about not just teeth and the smile, but you've got to start looking at the eye level. Because what is that? The eye level is basically your position of your sphenoid bone. The sphenoid bone is a bone that is basically shaped like a swallowtail butterfly. There are greater wings and lesser wings. And the greater wing of the sphenoid bone is the back of the orbit of the eye. If you have an eye that's off, the sphenoid bone is off, and the sphenoid bone is a central cog of all these cranial bones. And then you've got to look at the ear level, because what does the ear tell me? Well, the ear tells me.
Let's back up just a little bit. For those that aren't familiar with the sphenoid bone is basically in the middle anterior third of the skull. And I can't remember not every cranial bone attaches to it, but most of the bones of the head are attached to that sphenoid bone in one way or the other. So if the sphenoid bone is off, it's a chain reaction for the rest of the face, basically.
And that's correct. That's why they call it the central cog, like a watch. Exactly. And then you have the ear level, which basically now, so the sphenoid bone tells you what is going on with the middle of the face, like Hal had said. The temporal bones are the back of the face, the back of the skull, I should say, and that's your ear. And so you're going to start to notice ear levels off, which is determined by this temporal bone and whether they're externally or internally rotated. And then you have to look at the smile, which is now the front of the face, because we just think we're looking at the front of the face the whole time, but we have cues, eyes, ears, smile, and then head tilt that tell us a lot about what's going on in the craniofacial structure. And then there's head tilts, and your head tilt is cervical instability, and that's huge. That can cause it be the result of many, many diseases and pathologies that are out there. If you have a head tilt, what you're doing now is you're kinking the hose. And now you're affecting the main blood flow from the vertebral artery and the carotid arteries to the brain. You're affecting the main drainage, the jugular from the actual brain. And you're also affecting spinal accessory nerves and the vagus nerve. And that's all C1 and C2. So it's really, really powerful. And if I told you I could put an appliance in and potentially affect the head tilt by just wearing appliance, you would be pretty amazed. And then facial asymmetry. So by utilizing an appliance called a open loop cricket, we're able to address craniofacial posture, airway, tongue position, cranial bone movement, and the autonomic nervous system. And the reason I say autonomic nervous system is because you've got to understand it with these cranial bones, there are 12 cranial nerves. They're named cranial nerves. Why? Because they pass through the cranial bones, through little fissures, ovales, rotundums, little openings. And if your cranial bones in your facial asymmetry is off, it is now affecting potentially the cranial nerves and their ability to innervate and do what they do. So you can take a case like this and within 3 months, start to level things out dramatically. And you can see I'm drawing lines not from the eyes, but from the orbital notches, which is a bony reference point. Even though we're using this over skin, we have an idea where that is. We draw a line straight down the center of the forehead through the philtrum of the lip. We're using the external auditory canals to tell us where the back of the head is. So we have the middle of the head, the back of the head, and now we have the front of the head. We have facial asymmetry one side or the other, and we can also look at the head tilt. And that's what these lines actually represent. And so we can take cases like Mallory, and within 3 months, with an open loop cricket, literally cause her craniofacial bones that are pretty much wedged and wound up to unwind and to go to a natural position. The one thing I learned from the chiropractic community is that if you put the body in the best position to function and allow it to heal by creating spaces and motion, the body will do that. So this is her. We are also affecting posture with her, as you can see. Forward head posture. Forward head. So one of my big epiphanies during this journey that I've had is TMJ. And so as a neuromuscular dentist, coming out of where I was out on the West Coast teaching, coming back to my private practice in Indianapolis, I got a ton of TMJ cases. And I started to treat these TMJ cases as airway patients because most of these TMJ patients have what? They have a forward head posture. Yeah. And every inch of ideal alignment of our body, our head's about 10 to 14 pounds. We add another 10 to 14 pounds to the hip. So if you're 2 inches out here to get air, and your head is now another 20 to 30 pounds, there are 3 muscle groups that have to balance the head: traps, scalenes, sternocleidomastoid muscles. And those muscles get all fired up. And what's interesting, if you look at Janet Travell's book, who wrote the book on trigger points, all of those trigger points are TMJ related issues or pathologies that you see. So the trigger points coming from the forward head posture and from the trap, scalenes, and sternocleidomastoid muscle now trigger to what we think are TMJ symptoms, but most of these cases are really forward head posture airway patients. So I thought, wouldn't it be nice to put our body in the best position to function 24/7, not just at night wearing an appliance, but try to correct the body and allow it to heal into a better position 24/7. And that's pretty much what we're doing with this appliance. So what does it do? We utilize a Lightwire technology and a pad of acrylic to allow the body to be able to heal. And basically, this is non-surgical, no medication, and no vacuum cleaner, CPAP machine. So my syntax for treatment is totally different than maybe many, because I'm looking at facial asymmetry first, because that basically is the template for the body. And so craniofacial posture dictates airway, dictates neurology. And so when I look at these patients, there's like a checkbox that most of them have. And you're going to see a head tilt. You're going to see facial asymmetry. You're going to see forward head posture. You're going to see and have them tell you pressure behind the eyes, cervical issues, sinus issues, blurred vision, headaches, vertigo, TMJ, and airway issues. And that's pretty much what we see with the majority of these patients. And if you look at all these symptoms and all these issues that these patients have, a lot of them can be directly related back to cranial nerves. And where do those cranial nerves go? Through the cranial bones. And what are we affecting when we let the body unwind and create more symmetry? We're affecting the actual cranial bones. And that's why I have about 50% of the patients that I treat that have vertigo, it goes away. And the reason for that is, and most of us are not taught this, but the vestibulocochlear system is located in the temporal bone, and that's your ear. And so if you have a temporal bone that's externally rotated and out and back this way, and the other one is over here, and now those signals are being sent to the cortex, the brain gets confused and is not really sure what to do. And maybe I'm getting dizzy, maybe I should lay down. But if you can correct that, as you're going to see with these cases later on, and correct the position of the temporal bone, a lot of these vertigo issues go away. And that's TMJ too. I guess I should just briefly talk about that. I don't have any visuals for it, but my feeling is most internal derangement cases, basically there's only two ways you can get internal derangement. Trauma, which is actually the rarity, or a lateralization or a gap that allows that disc to slip into. And that's where you see this externally or internally rotated temporal bone causing this internal derangement. So if I take the cause of that TMJ and correct it by correcting the cranial bone positioning, it's not just voodoo that this TMJ starts to go away. 2, 3, 4 weeks into this treatment, clicking and popping is going away. And the reason for that is we're treating the root cause of the TMJ, not just treating it as a Band-Aid.
So the root cause of TMJ besides trauma is malpositioned temporal bone, or
yes,
the temporal bone is
rotated,
strained, rotated out of its proper position.
yes.
And this can only be a minimal, just a matter of millimeters that can make a huge difference in the function and health of the TMJ, correct?
That's correct. Absolutely. It doesn't take a whole lot. So if you got a condyle on the disc in a closed pack position and it's moving up and down, things are great. How can that closed pack position get array? And basically, if you have a temporal bone that's lateralized, in temporal bones, when they externally rotate, they go out and back. When they internally rotate, they go in and forward. And so if you have an ear that's abducted, so that's a temporal bone that's externally rotated, and now it's going to go out and back, now you've created a lateralization or a gap for the disc to slip in. And what's interesting is, where does the mandible go? The mandible goes in that direction. Why? Because the temporal bone in that fossa is out and back.
Mm-hmm.
So what I look at is, we all focus on the sagittal view of the airway, which is good, and we should. But I'm also thinking about the frontal view, which nobody really focuses on. And I'm also looking at the axial view, and I mentioned this early on. We're so focused on the size, but the tone is critical. And I have my patients do exercises with a relaxator to help tone the airway. And so if your airway is not toned properly, it doesn't really matter as much the size, but the tone is critical. And what is interesting about that is the tongue is so important with that. So the tongue is basically attached directly to the airway by a muscle called the glossopharyngeal, glossal tongue, pharyngeal airway. And so the glossopharyngeal muscle allows the airway to be toned. So what do we see with most of these cases? The tongue is what? Down, back, in between the teeth, scalloping boards of the tongue. It's a great orthotic, but it's not where it's supposed to be. So when that tongue is down and back, the airway collapses. When the tongue is now anterior superior, up and forward, now that actually tones the airway because of the glossopharyngeal muscle. But the other, that's inside. If you look at outside, you have the ubiquitous oris, which are the lips. You have the buccinator attached to the back of the airway by the pterygomandibular raphe, which is kind of like a Lego connector for muscles. So now you have two things going on. And if you're doing that properly, that airway is going to be more toned. And I tell my patients, it's kind of like going to the gym. If I don't tone my airway, like if I don't go to the gym for 2 weeks to 3 weeks, I start to atrophy. And so you've got to keep working that airway and keep toning that airway to be able to tone that muscle. So
Don't you lose it.
what's that?
You don't lose if you don't use it, you lose it.
Absolutely. Absolutely. So it's kind of like when I look at head tilts, I'm thinking about kinking of the hose. It doesn't take much to kink that hose. And then I'm thinking about neurology because we talked about this. You've got all these cranial nerves and you got the vagus nerve and you have all these spinal accessory nerves that are going through there. By the way, we'll just look at this picture really quickly. There are 12, there's really 14 cranial nerves, but we're going to focus on 12. There's obviously the very first one, olfactory, which goes through the cribriform plate, which is the frontal bone. You have 5 more that go through the sphenoid bone alone. You have 5 more that go through the temporal bone directly or indirectly. And then you have the hypoglossal, which goes through the hypoglossal canal, which is right by the magnum. Actually, it's right here, the magnum foramen. So cervical instability, head tilt is huge. So once again, posture dictates airway, dictates neurology. So I learned a lot of this going through down some rabbit holes with the chiropractic world. And I grew up in a family where my dad and my brother were pediatricians. And basically, chiropractors were known as quacks. and that was my mindset. And so early on in my career, that's what I was thinking. And I never forget, about 2 to 3 years into my career, I'm young, I'm green as heck. I still don't know much, but I did know a whole lot then. And I'm like going to myself, why are these patients coming in and they're going to traditional Western medicine and not getting any treatment or not getting any relief? But they're going to a chiropractor and they're getting relief. And I thought to myself, that's kind of strange. So I kind of went down that rabbit hole and one thing led to another. And I do give Dr. Bob Walker a lot of credit. He taught me a lot about chiropractics and what's going on, but that was huge for me. So I had questions. Why? Where do we start? How do we get here? What do we see and why? What do we look for? Here's the kicker. What are we trained to see? What are we not trained to see? Because we're not trained to see a lot of what we're talking about right now today. And why isn't the treatment as effective? And so to do this, you have to kind of start to think about quantum physics, which is really vibrations, frequency, energy. It's basically what affects the whole universe and what affects you. We have to talk about electric fields and wavelengths because we have that in our body. Wavelengths are huge. I mean, it's the law of attraction. That's basic physics. I met Hal and it was like I knew him for 20 years. It's just law of attraction. We're on the same wavelength. So it's called constructive interference. When you're on the same wavelength with somebody that you've met, basically it's constructive interference and it's amplified. It's like you get along great. You've got it. If you meet somebody and it's destructive interference, it cancels out and it's like, I don't know, maybe we're not going to get along. But that's basically what this is. And this is what you throw off. We've got to talk about stem cells and epigenetics. Epigenetics basically means epi on top of the gene. The genes just sit there. They're like blueprints. But what runs the whole system are the vibrations in the energy and the signals that are sent to the cell membrane that tells you what to get in and tells what proteins to read, to turn on, to turn off genes. And so that's basically epigenetics in a nutshell. The cell membrane is the determining factor, determining what signals hit the cell membrane and what signals go through, what they do, what pathway they go down to the nucleus. That's signal transduction going through the cell membrane. And that's something that is very important. There's signal transcription, which is basically cleaving off little nucleotides to create a new sequence. And then there's translation, which now goes out through the transduction of the cell membrane again to little ribosomes, like little Xerox copy machines. They create a whole new protein, which is a brand new behavior. So in a nutshell, that's kind of what this is doing. And by the way, stem cells are affected by the environment. Bruce Lipton, who's a real interesting man, who basically is the father of epigenetics, did a really interesting experiment where he took a bunch of stem cells, same stem cells, put them in 3 different petri dishes with different environments, different mediums, and they all turned out to be different. Whatever the environment was determined what the fate of those stem cells was. So the environment is just critical. You talk about biotensegrity. Biotensegrity is based off of tensegrity. And tensegrity is a concept where you see these structures, they're like floating in air. There's no pillars or columns holding them up, but they're just there. And they're held up by compression and tension elements. And we have that same concept in our body. It's called biotensegrity. And in our body, on a macro level, I won't get into the microscopic level because we don't have time, but in the macro level, when you talk about tension elements, you're talking about ligaments, fascia, cartilage, and when you look at compressive elements, that's bone and teeth. And we're held up by fascia. Fascia is a connective tissue. There's no beginning, there's no end. And what's interesting about fascia is its derivative, where it is formed initially histologically, is in the mesoderm, which is what? Right in the middle of ectoderm, endoderm, mesoderm. And then there's mechanotransduction, which is basically taking signals and showing how those signals are able to go through the body biologically. And that our body communicates via mechanotransduction. There's piezoelectric energy, there's vibrations, there's frequencies, there's energy. And so to understand this whole concept, you've got to realize as a dentist, you got to start thinking about this because this is really how the body in the universe actually works. So signals cause behavior. If you don't have signals, you have no behavior. One of my favorite quotes is from Neil deGrasse Tyson. The greatest challenge in life is to know enough about a subject to think you're right, but not enough about that subject to know that you're wrong. So the challenge that we have as dentists is there's a major disconnect with how we're educated and trained. And I'm not criticizing dental schools at all. They have an incredible tough job and they have really almost an impossible job. But what we are trained to do and to look at is to look at the parts and the pieces, the teeth. And that's the Newtonian approach. And we need to do that. We need to know the parts and the pieces. What we fail to do is to learn how those parts and pieces are affected by the medium, the matrix, the environment. And that's what we really need to start to understand as dentists. If we want to look at dentistry and think about teeth only, you're going to miss the whole boat because we as dentists probably have the most powerful tool in our toolbox to be able to treat and help the overall health of patients. So once again, as a cosmetic dentist, early on in training, I would look at the smile. But when I start to look at the face and the eyes and the nose and the ears and the maxilla and the cranial system, sometimes we make these cases even worse because we're not addressing the craniofacial posture first before the rest. This is a orthodontic before and after case that I found on the internet. The teeth look great. The face looks worse. You just have to start thinking about what we're doing. So how do we really get here? In my mind, there's 5 environmental factors that affect craniofacial development. Basically, sitting in the pelvic girdle is gigantic. That's kind of where it all starts. Then you also have going through the birth canal, C-sections. Then you have basically mouth breathing, but you also have hard diet, chewing, and then you have nursing, myofunctional. And those are the big things that I think affect the actual development of the face before you're born and then once we were born. So when I look at patients, what I learned and what I know now from the craniofacial standpoint has totally changed the way that I look at my TMD airway patients. If you change the way you look at things, you change the way you look at things. And so when I look at these patients now, I'm thinking cranial strain patterns because each one of these patients has a particular cranial strain pattern that kind of fits it. And so what I'm going to do is take these patients, recognize the cranial strain pattern, and treat the cranial strain pattern to allow the body to create gaps in spaces in motion so it can heal. And this is really what this is all about. And so with a open loop cricket, if I'm going to treat a patient, and they don't always need to go this route, they don't always need to have a top and bottom. And that's something that's got to be determined by obviously the practitioner, the dentist. But on the top, what we do is we take a open loop cobalt wire that has a resonance frequency very similar to the body, about 35 to 40. The body is anywhere from 0.2 to about 100 to 200. And we're also going to put a block on it. And this is really the key, because if you put a block, we have what's called a closed loop kinematic skeletal chain. That's our body. It's a closed loop, and there's two openings to this body, the arch of the feet and the bite. So every time you bite together after a swallow, and once your tongue gets out of the way for most of these patients, you come together. And when you come together, you lock yourself back into that system. If you take a really, really talented osteopath and have them cranially move those bones, and then tell that patient to bite together, those teeth are not going to fit together right away. And that's how you know whether the bones have actually been moved. So every time you come to the end of a swallow and put your teeth together, you lock yourself into that system. So all these cranial bones that are wedged, this craniofacial asymmetry, are locked back in. The only way that you can allow that to change is to create a gap or a space. And that's what this block does. And so the best analogy I can give you is kind of like a puzzle with a bunch of colored blocks. If I got a bunch of colored blocks together and take that middle yellow block and try to move it, it's not going anywhere. It's locked in, kind of like these cranial bones. If I take that middle yellow block now and take it out, all of a sudden the adjacent blocks start to move. Why? I created a gap or a space. And that's what this little block does. The magic of one little piece of acrylic that is higher on one side versus the other. So when the patient bites down, it creates a gap or a space, allows these cranial bones to start to be able to move in a more ideal position. And that's the glory and the cool thing about the human body. If you
those of you that are watching this, the pad on the left, which would be the patient's right, is actually thicker than the pad on the left on the patient's left. So
yes,
they're only occluding or touching on that one side.
yes, thank you. And then once again, this is the lower. The lower does not have any pads on. The magic happens up here in the top. Because that's where all the cranial bones are. But here's the bottom. This is a lower cricket. And once again, this wire is made out of cobalt. It actually has a memory to it. It's very flexible. And even though it crosses the midline, it moves with the body and moves with the fascia. And that's the cool thing about this. So when I look at my patients, I can literally walk in a room and within about 10 seconds have a pretty good feel for what's going on, because I'm looking at facial asymmetry. As they're talking to me, I'm looking at where the mandible is going, right or left, and I'm looking at their head tilt. And right there, I have a very, very good idea as far as what's going on. And once again, I use these reference points, and this is via Bob Walker triplanar analysis. I give him total credit. But I use, even though it's skin on top, underneath, what do we have? Fat pads and cranial bones. And I'll use reference points to be able to use landmarks to determine facial asymmetry and what parts of the face are on or off. And so I'll draw a line from this orbital notch across, and that tells me where the middle of the face is, because that's where the sphenoid bone, frontal bone, zygoma come together right here. This suture right here. Then I'm going to look at the ears, and I'm going to draw a line from the external auditory canal across. And now that's telling me, not the front again, that's telling me the back of the skull. What's going on with the back of the skull? And by the way, the mandible is the connector from the back to the front. And a lot of chiropractors consider the actual teeth as another suture as they start to come together, because it is part of this whole skull cranial system. And then I'm going to look at the maxilla, and that's going to basically tell me the front of the face. And then I'm going to draw a line straight down the middle, right through the philtrum. And there I'm going to be able to tell right side, left side, facial asymmetry. You're going to normally see one side that's a little bit narrower than the other side. And that's the side that's internally rotated in versus the other side, which is out. And I don't know if I have a case to show you, but what's fascinating to me, there's not just one thing to diagnose. It's like a bunch of pieces of the puzzle you're putting together. But if you look at a woman's hairdo and you look at how the hair lays on the face, they usually will put the hair next to the face on the narrower, steeper side and away from the face on the more convex, fuller side to create more of an illusion for more symmetry. And it's pretty interesting. And so here's our first case. This case was basically slated for orthodontic surgery. And my orthodontist here in Indianapolis called me up and said, Timmy, what do you think you can do with this case? And I said, I have no idea. And I tell my patients honestly, I have an idea maybe, but I don't know where all these cases are going to go to. Why? Because it's so multifactorial. It's like peeling the layers of the onion off. You really have no idea for sure. But she was slated for orthodontic surgery. She didn't want to do that. I'm looking at her face going, look at that facial asymmetry. Look at her head tilt. Look at her ears. Look at her maxilla. Look at her eyes. Maybe we can help her. And so we went ahead and treated her. She was what's called a right torsion case. And if you look at her, her right side is narrower and steeper than the left-hand side. And by the way, if you look into the maxilla of these patients, it will match too. The right side of that maxilla of the internally rotated side is going to be narrower and steeper. The left side is going to be wider. And what you're going to see also is, look at that ear. That ear is abducted. Well, that ear right there tells me that that temporal bone is externally rotated. So now she's talking to me, and I'm looking, and I notice, look at her mandible. Her mandible is swinging way over to the right. And oh my gosh, that's the same side that the ear is abducted to. Why is that? Because the condyle of that mandible fits into the fossa of that temporal bone. And if that temporal bone is externally rotated, it is out and back, and that drives the mandible in that direction. In addition to that, now you've created a lateralization or a gap for potentially the disc to slip in, internal derangement. If I treat that externally rotated temporal bone and allow the ears to come back in a little bit, all of a sudden the TMJ is helped, sometimes totally healed. And here she is. Wow. This is about, I think, about 10 months of treatment. And by the way, when I take these pictures, they just come in, they sit down and stand up, and I just shoot pictures. I don't tell them to tilt their head one way or the other. To me, a frontal facial shot is huge. Here's another left torso.
Go back to that, Tim. That's about 10 months of treatment with full-time wear, of course, taking it out to eat.
Actually, you're only wearing that at night.
Oh, just nighttime wear. Okay.
That's the glory of this.
Yeah.
So a lot of the growth hormones are active starting about 3 or 4 in the afternoon until about 8 in the morning.
Okay.
And so that was why initially we started to say at night only. The other thing that's interesting about this, I'll go off a tangent here if you're okay with this.
Sure.
So J.J. Mayo out of Columbia University did a ton of studies on forces and forces on stem cells and how those forces affected those stem cells and how they differentiated. And this is in the literature. It's big time, not just J.J. Mayo, but others. And so what he determined and found is that if you take static constant forces and put them, let's say we're talking about osteocytes, cranial sutures, bone cells, and you put those static forces on those stem cells, they're going to differentiate into osteoclast for bone breakdown. That's traditional ortho. How does it work? You got to break down the bone where the force is going, away from it. You got tension, pulling, you got bone growth. If you take those exact same stem cells and put light, cyclic, intermittent forces on them, they will now differentiate into osteoblasts for bone growth. That's the key to this whole thing. That's what the actual open loop cricket does. It's light, cyclic, intermittent forces, only worn at night. It's not static forces. It's not expansion. It's development, allowing the body the ability to do its own thing and develop. So here's a left torsion pace, and you can see left side is narrower and steeper than the right side. Her ear is abducted out a little bit. That's where everything goes. And if you look at this, you can't really see her ears as much, but you can tell, like this ear, if you look at this and now look at it here, it's out a little bit more. So we're starting to get some more symmetry there. Mm-hmm. I'll let you just look at these. Look at the difference in her forward head posture. And wow. All these patients, not all, majority of these patients have cervical issues. Why? It's posturally related. And then you tie in the trigger points and then the body having to accommodate. You know, the chiropractic community taught me that how long you live is how well you're able to accommodate. So I can put somebody in a neuromuscular appliance and make them better because they're accommodating better. But really, from a biointegrity standpoint, if you affect one part of the body, it affects the whole rest. What is that doing to the whole rest of the body? And we can't really measure that, and maybe you'll never know. But my feeling is, let's get this corrected first before we do anything else. And then there's our posture. So in the chiropractic world, there are what we call ascending and descending issues. And descending issues are issues that are above the neck that drive down this chain. Ascending are issues that are below the neck that drive up. It's never one or the other, but it can be predominantly more one than the other. Yeah. In my experience, when I'm treating patients the way we're treating them, if it's more of a descending issue, you're going to have more of an effect on the posture overall, because that was the actual guiding force that was basically causing all the problems. Yeah. If you talk to chiropractors, although most of them don't know and most dentists don't know, but the most challenging cases that chiropractors have are descending because they're not looking at the dental aspect of it. The most challenging cases that we have as dentists are ascending because we're not getting proper team members on board. SOT, craniosacral, osteopath. We're not getting those people on board to be able to help us. It's got to be a team. You cannot do it on your own. This is a really cool case. So she's a student down in South Carolina. So I don't like out-of-town patients because I can't follow them that much. I mean, it sounds really great, but I really don't like it. But basically, she goes to school in South Carolina. So I see her on the holidays, about every 6 months. So she's a right torsion case. So 8 months, I was like going, I mean, there's improvement. Would I like to see more? Absolutely. She comes in 20 months and she's like almost perfectly symmetrical. And this is just with wearing one of these devices at night only. And here she is 26 months later. She came back again recently.
That's amazing.
This is one of the first. So a few of these cases you're seeing were treated with homeoblocks, and a few are going to be open loop crickets. The one thing the open loop cricket has in common with the homeoblock is a piece of acrylic to allow for a gap or space. Yeah. The thing that the homeoblock did not have, that the open loop cricket does have, is the ability to move with the fascia and move with the body and cross the midline, yet not constricting the cranial fluid flow because we're not constricting the cranial motion. So
the homeoblock has a gear, right?
It has a gear, but
if
it's, I don't want to get into the nitpicky things about this, but it has a gear. It's a jack screw.
Yeah.
And you turn it just to keep up with the cranial bone changes.
Yeah.
And there are these little light lever springs that if they're made properly, they literally just go like this. And as you start to develop that, once these cranial bones are in their most ideal position, but you keep turning that, those little finger springs start to ride up over the teeth.
Yeah.
So it's not supposed to be forced expansion. If you embed those springs with acrylic to the end of the loop, you are now creating a Schwartz appliance for active expansion. And you don't want to do that. Yeah. And you know where I'm going with that, but I'll stop right there.
Right.
So the reason I wanted to bring all this up was that, so Ted Belfour never treated kids. And so I kept asking him, I said, why can't we treat some kids? Oh, you don't want to do that. You don't want to do that. And he didn't treat TMJ with it either. And so I just thought to myself, why? I don't like the answer. So this is one of the first kids I treated with a homeoblock, not an open loop cricket, just with a homeoblock. And so I talked to the parents. They were all on board. This is a side bending case. You have lateral torsion cases. You've got side bending cases. There are anterior, posterior, and lateral torsion cases. There's a study done at Michigan State University. I have it in one of my lectures. A study done, and the majority of the cases that you're going to see, they're going to be right side bending torsion cases. But they have a mix of other things in with them too. So it's not just one or the other. These are a little more challenging to actually treat. But with kids, with the homeoblock, I couldn't put a homeoblock in a child until about 6 years of age because it has to attach to the first molars. So I had this window between 6 and 12 because at 12 years of age, when that second molar erupts and drops down into that bundular bone, it now causes that maxilla and the palatine bone to lock into the actual sphenoid bone. So you don't get as much of the magic as you would. And so we went ahead and treated him. And I remember he's a side bending case. He fits it just perfectly. 2 weeks, he comes in. When I see my patients, I always look at their pictures right before I go in to see them. I looked at his picture. I had no idea what I was going to see. I walk in the door. I look at him. I turned to Wendy, my assistant, and said, grab me the camera. Because it was like, oh, are you kidding me? It unwound fast. 2 weeks, look at the difference in his face. 6 months later, look at his posture change. Look at the difference in his forward head posture. I've created a template for this kid to thrive so much better the rest of his life. 24/7, not just wearing appliance at night. This is a really interesting one. This is a side bending case, another challenging case. And look at the ear. So she opens and shuts, and where's that mandible going? Boop, over here. Why? Because that temporal bone on her left side, our right side, is externally rotated. It goes out and back, and that drives the mandible in that direction, and it creates a lateralization and can create internal derangement. 20 months later, look at the difference. Look at her ear. Look at her eye. Look at the facial asymmetry. Look how her right side, our left, is so much narrower. And now all of a sudden, look how much more symmetrical she is. And all we did was created a gap or a space to allow these wedged cranial bones to unwind on their own. And once again, I've said this a few times, but if you put the body in the best position to function 24/7, it will do that.
Amazing.
Forward head posture and posture. So she was more of a descending case. So what we did upstairs as a dentist affected her posture more so than what maybe somebody downstairs could do moving up.
So Tim, are you getting transverse width, for lack of better words? I know we don't use the word expansion, but are you getting the maxillary jaw, some widening in that as well to help open the airway?
With the cricket, yes.
So you're getting that along with
The block. So we're getting
the cervical balance, which also opens the airway as well,
yes,
because the hose is not kinked.
yes, absolutely. And then once again, I don't talk about it as much. I haven't on this, but I do in my lecture. You know, the tongue is king or queen.
Yeah.
If you don't have the space for that tongue to go where it's supposed to go,
Yeah.
it's affecting your airway.
Yeah.
So, and then here's another case, left torsion case, 16 years old. Look at her nose, by the way. Look at the change in her nose.
Mm-hmm. Yeah.
Look at the change in her posture. She's got that kyphotic military look right here.
Yeah.
Here's little Josie. She's another one where 2 weeks later, I walked in and said, holy cow, look at this. And then 5 months later, and then this is the last case we'll talk about. This is Mallory. So Mallory was the very first open loop cricket case I did. So do you want to know the history of the open loop cricket and why it's called that? So Dave Gergen, who I'll talk about at the very end, is a master lab technician, orthodontic, world-renowned. Worked with a gentleman by the name of Dr. Bob Ricketts, who is a world-renowned orthodontist, who everybody that really knew him would say that he probably was the best dentist that ever lived. He knew epigenetics and quantum physics back when there was a term for it. He understood it, but he didn't know really what it was. And so crazy. So Dave Gergen called me up about 10 months ago. I knew Dave back in 2007 to 10 because I was doing some sleep lectures down in Phoenix, and I met him there. Had him come to Cleveland because I was teaching an inclusion, ran an inclusion course in Cleveland. And so he called me up out of the blue about 10 months ago. I said, Timmy, what's going on? What are you doing? He said, I hear you're doing some interesting things. Let's do a Zoom. So I did a Zoom, and I thought it was just going to be him. And on the Zoom, there were 2 sleep physicians, 3 dentists, 2 lab technicians, him. It was supposed to be an hour Zoom and went 3 hours because I was just telling him what I was doing. And he said, you got to get down here. So I said, I'll tell you what I'll do. 2 weeks, I'll fly down. I'll spend a weekend with you. I went down there, spent a weekend with him. I'm in his lab on Saturday. he pulls out this big, gigantic suitcase, opens it up, and he's got all these freaking, I thought it was at the Antique Roadshow, all these appliances. It was crazy. And so he started going, because I'm going to, tell me about him. I'm going to learn about him. He starts going through these appliances and he pulls this one out. And he says, this is a Cricket. It moves with the body. It moves with the fascia. I'm like, stop. Are you kidding me? I said, can we put an acrylic pad on there? He looked at me and said, yeah, why? I said, this is it. And that was the beginning of the open loop cricket. The reason I call it open loop cricket is because we talked about it. We have a closed loop system. And every time you bite together, you lock yourself into that system. You lock these cranial bones where they're going to go. And not unless you manually move them and then change the occlusion right away, they're going to be back to where they were. What an open loop cricket does is it opens up the closed loop system by creating that gap or space by the patient only hitting on one piece of acrylic. And that was the open loop cricket. And that's, so it's a cricket. And by the way, it was called a cricket. The crozet was the first beginning part of this. And then the cricket was derived from the crozet. And then you have the elf and some other appliances, quad helix, etc. But basically he called it the cricket because he was treating kids with this. And because of Jiminy Cricket, the cartoon character, and he actually wrote a little book that gave to the kids, it was called the cricket. So that's why it's the cricket. It's open loop cricket because we're utilizing the cricket with an acrylic pad on it to open up the closed loop system to allow the magic to occur. So here she is. We treat, this is 3 months into treatment. By the way, she had every symptom that was on that initial blurry vision, pressure behind the eyes, dizziness, headaches, cervical issues, the whole thing. And most of those symptoms are no longer. And she was great because she was at my very first lecture that I presented to her, and she was able to get up and tell everybody, well, it was like, walk the talk, dude. Here it is. And then here's her posture. Look at the change in her forward head posture. You can tell she's almost leaning over. And now her balance is so much better. So I want to thank Dave first because without Dave, I would not be here talking to you and Hal and everybody out there. And I do want to plug ASBA, the American Sleep and Breathing Academy, because once again, I think it's the best sleep organization out there. It's basically noted by Medicare, by PCAT. I mean, it's basically really, it's a high level of education. It's not a rah-rah type organization. It's, you want to learn, you want to be academic, and you want to be able to go home and treat your patients the proper right way. I think this is where it's at. And they have diplomat programs, they have mastery programs that we're developing right now. So go to the website if you want, but I think it's a great way to go. So
I agree with you, Tim. Tim lectured at the ASBA meeting earlier this year, and I was honored to be able to lecture as well. I'll also be lecturing at the ASBA next year, so I'm
right
excited.
on, which we love. We love it.
Yeah, and Dr. Cordor and I both have got our diplomat status with it. I agree with you, Tim. It is an incredible organization, really hardcore on science and research and treating the cause of breathing disorders, not just treating things with a Band-Aid. That's the focus of the SBA. So it's an honor to be in that organization and to meet Tim. And we'd actually met back in the 90s in our cosmetic journey
Yes,
a long
yes,
time
we did.
ago. Such a great organization.
No, and the great thing about this organization is not the people that are running it. It's the people that are involved with it, and it's the members. And to get somebody of Hal's status to be able to come and join us was like, are you kidding me? This is great. So, I mean, we're honored to have you, Hal. We can't wait to have you speak next spring in Phoenix. And I think it's great. I don't have it up here, but I will supply. I've written 3 articles so far on this. I have 2 case reviews. You saw both of the cases that I wrote articles about.
Yeah.
And then I spent a little time, a little time. By the way, I hate writing, but I do okay with it. I hate it though. But anyway, so I wrote a 28-page article that's referenced and cited in the literature on everything I just talked about, from quantum physics to tensegrity, to fascia, to open loop critic, all that stuff. It all ties together, and I've cited it in the literature. So
we'll have Alexandra put those links
and
on.
my contact information too.
Yeah, and your contact information. So for those of you that aren't watching this, go back and at the very least go to the end, and she'll put Dr. Adams' contact information in those links to his references to his articles.
So any questions, Hal, that you have, or anything that you want to go over before we cut it?
Well, that was about as thorough as you can get in a 45-minute to
Well, thank you.
hour synopsis of what you and I and the others talked about for 2 full days a few weeks ago.
Yes.
So what I would like to do is have you back on. Maybe we can take a few of these subjects and go a little deeper into them, like cranial nerves, and what cranial strains can do to each cranial nerve and how that is related to the body. So
Love it. I'd love to.
I don't really think there's anything that I could add right now from a standpoint of asking you any questions. You covered everything. It's so funny. About half a dozen times I thought, I need to stop him and ask him this question, and then 2 or 3, then I'll think, oh, let me just wait, and then 2 or 3 minutes later, you answered what I was going to ask. So
I got lucky today, Hal.
yeah, sometimes the best interviewer is one that just shuts up and let the star talk. So
well, you did a great job, by the way. And once again, I'm honored to be on this podcast that you're hosting, and I would be delighted and flattered to come back again.
We definitely will. And you know what I think would be really cool is coming in and I could put up a case and we could talk about it, and you can not critique it, but comment on it, and maybe even have a couple of other dentists do that, because I think that not, like I said, we have a viewership here with physicians, dentists, chiropractors watch this podcast, myofunctional therapists, lay people that just want to learn more because they have a loved one or themselves that they want to get better. And when I think seeing live cases that actual of real people that are walking around, in their particular cities and their jobs that are being treated and their lives are being changed is very, very powerful. And I want to thank you for showing the cases that you did show. Those were wonderful. And those are just everyday American people that are suffering that you're helping. So that gives, I think, one of the best things that we can do. And Dr. Corridor and I always say this, and we tell our team, when people come to us, many of them are on their last, they're searching for answers. And if we can give them hope, that goes a long way. And seeing cases where people just like them are being healed is powerful. So I appreciate you showing those actual cases.
I'll just add one thing really quick that goes along that line. The patient that I showed that had the ear that was way out abducted, she had been treated with 7 different appliances. And it took her husband 2 years to finally give in and say, okay, let's do this. And I didn't have it up, but her symptoms and what it did to her and for her were pretty crazy. So, but thank you again.
Because as dentists, there's all kinds of appliances out there, and for the most part, most of them do pretty much the same thing. They're just a different design. But the unique thing about the open loop cricket is that it's combining the monopad on one side of the body to throw, to open up that loop, along with the Lightwire intermittent cyclical forces to remodel. And that combination is powerful, very powerful.
No doubt, for sure. So listen, I thanks again for having me. I appreciate it.
Been wonderful. I can't tell you how much I appreciate it. This is going to be a highly viewed podcast. I can just tell it.
I love it. Thanks, man. If you want to talk later on, just let me know. I know you talked about that.
You bet. Well, I do have a case that I want to just talk about for a few minutes.
You want me to stay on?
When we're done here, yeah. So
okay.
This has been Health and Harmony Beyond the Teeth with our guest, Dr. Tim Robbins. We'll definitely have him on. Tim Adams. I'm sorry, I've gone
I thought you were going to talk about the scissors hand,
I'm
man.
thinking of Tony Robbins.
Oh, listen, if you put me in that category, I'm really flattered, bro. Let me tell you.
But we appreciate it so much. And we'll definitely have you on again. A wonderful colleague, and I consider him a great friend too. So,
Well,
gentlemen,
likewise,
so much, and we'll see you next time.
it's mutual. Thank you.